Now I would like to call upon Dr. Ankita Dembla for a presentation on applied imaging for salivary gland tumors. She is presently serving as a consultant radiologist at Sterling Hospital's Gandhidham.
Hello everyone. Today I would like to thank the organizers of Home 9.0 for inviting me for this session. Today I'll be discussing about the applied imaging anatomy of salivary gland tumors. Okay, so the learning objectives for our presentation would be what are the red flag signs, what are the common lesions, relevant anatomy, looking for classical radiological signs, and most important, perineural spread of the lesion. Okay, so we'll go to case 1. A 34-year-old female comes with painless swelling in left parotid region. So she comes to our radiology clinic and we do an ultrasound. On ultrasound, we see that there is a lesion present in the parotid gland which is well defined. It has lobulated margins, it is hypoechoic, and it has some peripheral edge enhancement. Oops. On color Doppler, we see that the lesion has peripheral vascularity and no definite internal vascularity. Next, we did an MRI. On T1 weighted images, we see that the lesion is very well defined. It is very well defined and it is having a lobulated margin and it is hypo-intense. Then we did a T2 weighted imaging and it came out to be hyper-intense. Then diffusion weighted imaging was done. On diffusion, we see that the lesion is hyper-intense and it does not show any corresponding drop on ADC images. This is important because all these signs radiologically point towards a benign lesion. When an FNAC was done for this patient, it came out to be pleomorphic adenoma. On T1 post-contrast imaging, we see that the lesion is showing heterogeneous post-contrast enhancement. So pleomorphic adenoma, importantly, it happens in middle age. It is a benign mixed tumor and it has both epithelial and mesenchymal components. It is usually solid, it is unilateral, and it is mainly present in the parotid glands. It can contain calcification. Now the lesion, if the lesion is small, it will be well defined, more homogeneous. But if the lesion is large, it can have a pedunculated outgrowth and it can have heterogeneous necrotic areas and heterogeneous post-contrast enhancement. Now on this image, we see that there is a lesion. The lesion is present in the sublingual region and it is well defined and it is homogeneous. It is homogeneously hypointense and it is not showing significant post-contrast enhancement. Similarly, we see this lesion which is present in the submandibular gland. These lesions came out to be pleomorphic adenoma in sublingual gland and in submandibular gland. Now coming to an interesting case, we see that on T1 weighted images, we are seeing a lesion which is hypointense. Then coming to T2, it is coming hypointense again. And then on post-contrast imaging, we see that it is showing heterogeneous enhancement. The point to be seen is that on T2, it is coming to be hypointense. This on FNAC came out to be carcinoma ex pleomorphic adenoma. Now the associated malignancies which are associated with pleomorphic adenoma include carcinoma ex pleomorphic adenoma, which is the malignant change which happens in a patient who has underwent surgery for pleomorphic adenoma. The others are, these tumors are important because they have high metastatic rate to lymph nodes, lungs, bones and brain. Then there could be carcinosarcoma, then there could be metastasizing mixed tumors. Importantly, which I had pointed out, this T2 hypointensity, it is in favor of carcinoma ex pleomorphic adenoma. Next, coming to the relations, these were discussed. I'll just show on MRI. This is the parotid gland. Anteriorly lies the mesenteric space. On its medial aspect is the parapharyngeal space. Then posteromedial is the carotid space. Then behind here it is the prevertebral fascia. Then here is the paravertebral fascia. Both the retromandibular vein and external carotid artery and facial nerve, they course through the parotid gland. Now division of parotid gland it has been discussed. Now on MRI, how do we say? It passes, an imaginary line passes posterior to the mandible and it crosses the stylomastoid foramen. The part of parotid medial to it, that is the deep lobe, and the one which is lateral is the superficial lobe. Now I would like to ask the panelists, why is this deep lobe involvement important? Okay, so the deep lobe involvement is more in favor of malignant tumor. Then coming to submandibular gland, I'll just show it on MRI that this is the submandibular gland which lies on the mylohyoid muscle. The sublingual gland lies anteriorly. Then here lies the genioglossus muscle, Genioglossus muscle is medially. Importantly, the nerve relation is that the lingual nerve and the submandibular gland, they course superficial to the submandibular gland and hypoglossal nerve courses deep to it. Next, sublingual gland. On CT, this is present in the lower down section and these are the sublingual glands. Now the Wharton's duct and the lingual nerve, they course in between the sublingual gland and the medial part of genioglossus muscle. There are multiple minor salivary glands which were discussed. Now the imaging modalities, first of all cyalography. This is mainly done to study the ducts of the major glands. These are the parotid and the submandibular gland. What do we do is that we ask the patient to squeeze a lemon inside his mouth so the duct becomes prominent. Then we give dye is injected and then we take some images. So on this we are seeing then the entire duct can be seen. Important in malignant tumors is that on cyalography we will see that there is a stricture without any presence of any calculus. So this is an indirect sign of malignancy. Other than that, we can do CT cyalography. We can do MR cyalography, which is done without contrast. The conventional cyalography is contraindicated in patients with acute cyaliditis. Then ultrasound, this is the go-to investigation. It is done with high frequency probe. The submandibular gland and the parotid gland are rich in fatty tissue, so they appear hyperechoic. The important thing is deep lobe of parotid gland cannot be seen on ultrasound. For that, MRI is a better modality. Then if we combine it with Doppler, it can help in assessment and differentiating benign and malignant lesion. The benign lesions have peripheral vascularity. However, if a malignancy is there, it will have internal vascularity more. The RI and PI values are also high in patients with malignant salivary gland tumor. CT and MRI. MRI is obviously the investigation of choice. It is to study the perineural, lymphatic and the intracranial spread. Diffusion post-contrast imaging is important. Then the newer thing is dynamic imaging, in which we give IV contrast and the imaging is done successively, and then we have to see the time to peak enhancement and then we have to see the washout. Then the spectroscopy is there. That is to then choline creat ratio is lower in malignant lesions. CT is important for osseous spread of lesion. PET scan, it is basically to look for recurrence, to look for small lymph nodes. Now hotspots. Mostly the malignant lesions will appear as hotspots on PET FDG. However, there are few lesions, benign lesions, which appear hotspot on PET. Those are Warden's tumor and oncocytoma. Okay, so distribution of tumor, I'll just give a brief introduction. 80% rule is there, that 80% are benign, 80% are pleomorphic adenoma, 80% located in superficial lobe, and 80% arise in the parotid. Importantly, the size of gland is inversely proportional to the propensity of malignancy. Now coming to another case, a 50-year-old patient comes for evaluation of a slow-growing mass in the parotid region, and this mass has been persistent for last 5 years. So on sono, we see that there is a well-defined hypoechoic lesion which has certain cystic areas within. Color Doppler was done and it showed marked vascularity. But important thing is that the margins are pretty regular. Then MRI was done. On MRI we see that on T1 it is heterogeneously hypointense, T2 FS it is heterogeneously hyperintense, and it shows minimal post-contrast enhancement. On FNAC this came out to be Warthin's tumor. Warthin's tumor is a slow-growing tumor. It has relation with old men and smoking. Mostly important thing is that these are multiple and it could present bilaterally. So the DD should be METS, lymphoma, inflammatory disease, and on scintigraphy these appear as hot tumor. So one more thing is, this can be solid, this can have internal cystic component, and they can have hot spot. So this is classical for Warthin's. Other benign lesions. So this is a lesion which is there in the parotid. It is showing heterogeneous pre-contrast density, and it has a small calcification within. On MRI we see this hypointense flow voids which are more characteristically seen on post-contrast imaging. So this is an hemangioma. This is most common in children, and it will have prominent internal vessels, CT, phlebolyths are there, and flow void will be present on MRI. Okay, coming to one more lesion. See, on T1 weighted, it is appearing well-defined, hypointense. T2 weighted, it is appearing similar to the rest of the gland. On post-contrast, it is showing minimal enhancement. So this is a case of oncocytoma. It is a vanishing tumor and can present as hot spot on scintigraphy. Next is the first branchial cleft cyst. It can present in children or in females. The imaging can vary depending on the level of infection. Others are lymphangiomas. Then there could be a lipoma in the submandibular gland or any other salivary gland, or there can be a schwannoma along the course of facial nerve. Importantly, the FNAC or biopsy will be suggestive of the diagnosis of the disease. Imaging can only guide us where it is leading to. The red flag signs for malignancy, it would have infiltrative edges, it will be a painful mass, irregular enhancement pattern, local adenopathies, low signal on T2, and diffusion restriction. Coming to this case, a 50-year-old male patient comes to with a painful swelling. We see that there is a lesion which is well-defined, present in the parotid, hypointense in the parotid region, appearing hypointense on T2 and showing marked enhancement on post-contrast imaging, and it has irregular margins. The irregular margins are in favor of a malignant lesion. This came out to be mucoepidermoid carcinoma, which is the most common malignant tumor of the salivary glands. The imaging of such tumors depend on the histology. If it is a low grade, it will be well defined. However, if it is a high grade tumor, the margins will be ill defined, and importantly, these have a nodal spread. Similarly, on USG and CT, the imaging will be similar. It can have calcification. Then is adenoid cystic carcinoma. It is the second most common carcinoma. It is an infiltrating mass with high propensity of perineural and perivascular spread. Mostly these patients come with paresthesias. On imaging, similar to the if the histology is low grade, it will have well-defined margins. However, if it has irregular margins, it is more in favor of high-grade tumor. And these have high propensity for perineural spread. Acinic cell carcinoma, it is the second most common malignant tumor of parotids in children. These can be multiple and bilateral. Lymphoma, okay, so the lymphoma can be a primary nodal lesion, it could be a presentation of systemic illness, or it could be a parenchymal lesion. These are mostly well-defined lesions and show significant vascularity, and diffusion, importantly, these have low ADC. The most important is non-Hodgkin lymphoma with predominance of large B-cell lymphoma component, and it has the patients with Sjogren syndrome, they are more prone to non-Hodgkin's lymphoma. Now one more mimicker is there, that in this we can see that the lesion is hypo-intense on T1 weighted images, and on post-contrast imaging it is showing heterogeneous enhancement and the margins are also irregular. So on imaging we will think that this lesion looks like a malignant lesion, but when an FNA was done, the lesions it came out to be autoimmune disease of salivary gland, that is benign lymphoepithelial lesion or the Godwin's tumor. Next, other carcinomas are adenocarcinomas, primary squamous cell carcinomas, salivary duct carcinoma, carcinosarcomas, or there could be paragangliomas presenting in this carotid space, which can present as a swelling in the parotid region. Coming to salivary duct carcinoma, it has ill-defined margins and it can show associated bone destruction. There can be low ADC with early enhancement, and it can also present with perineural spread. Okay, the METs, rarely parotid gland lesions can be as a result of METs. It could be because of intragranular nodes, because they drain the face, external ear and scalp. It could be related to skin malignancies like melanoma. That is the most common primary tumor which is presented as METs. Others rare are RCC, lung, breast and GI carcinomas. Now coming to an interesting topic, that is the perineural spread. For perineural spread, important thing is the auriculotemporal nerve, which serves as an extracranial bridge between the facial nerve and the trigeminal nerve. So auriculotemporal nerve is a division of the third division of trigeminal nerve, and it connects the facial nerve in the region of parotid gland. So any lesion present in the parotid gland can present with intracranial MET because of the perineural spread of the disease. I'll show this interesting case. This patient had mucoepidermoid carcinoma and the lesion was resected. Post resection, the patient presented again with pain in parotid region. So MRI was done and we can see there is enhancement in the parotid region, resectable part, and also in association with that we have an enhancing lesion present posterior to the pterygoids. This is the classical pathway of the auriculotemporal nerve. The patient was on different other slide. It showed that there is enhancement present in the region of the auriculotemporal nerve, as well as there is enhancement present in the region of stylomastoid foramen. Next imaging, if we see on post-contrast imaging, we see that there is a lytic lesion with enhancement present in the region of mandibular foramen. So this indicates that the auriculotemporal nerve is affected. As it is a bridge between the trigeminal nerve and the facial nerve, there is enhancement present in the region of stylomastoid foramen, as well as there is enhancement in the region of mandibular foramen. With this, I conclude my lecture.
Does the pleomorphic adenoma and adenoid cystic carcinoma often mask features masking on the MRI?
See, if the lesion is small, the margins will be regular. But if the lesion is large, the margins will be irregular for pleomorphic adenoma also and for the carcinoma also. So for such cases, the FNA or biopsy is the main thing to differentiate between two. But other than that, if we do MRI and if we do diffusion weighted imaging, like in pleomorphic adenoma, there won't be any drop on ADC images. But if in case of carcinoma, because of high cellularity, there will be a drop on ADC images.
Do you think PET CT would be a helpful option in that?
PET CT will be helpful because pleomorphic adenoma will not be seen as a hotspot, but a carcinoma will be seen. Thank you so much.